All right, so today we're going to show positioning for an AAS. Sometimes they refer to that as a three-way abdomen. It's basically one view of the chest and then two views of the abdomen, one upright and one supine. So what we're going to do is set everything up first. In that imaging, I would likely do the chest x-ray first, so I'm going to set up for a PA chest. And 110 at 1.2, 72-inch SID. So I'm going to come set the room up for that. So sometimes with this, the condition of the patient is such that they've got things that are going on potentially with the chest and or the abdomen. So sometimes what they'll do is order an AAS so that they get views of both of those so that they can diagnose accurately. So my patient, I've already seen my patient, and she is Sthenic. So we're going to do her PA chest lengthwise. My markers are super sticky. I'm going to put left marker on there, and I will get my patient, and then we'll get set for that. All right, Jordan, come on in. So in the other video, we explained history taking and changing the patient. So for this, she would have everything off. Shoes and socks would stay on, and she would have a gown on open to the back. No jewelry, no piercings, no nothing. So what we're going to do is have you come over here, and we're going to have you face this board for me, right up against it. Good, as close as you can. Kind of hands on your hips for me. Just kind of roll your shoulders forward. Good. I'm going to poke on you a little bit and find some landmarks. So inferior angle of the scapula and midline would put us at T7. So that looks good like that. Markers there. Shoulders rolled. Good. Your chin does not have to go up on that. I would probably be mindful of her hair clip. Can I move it out? Mm-hmm. Just so that I'm not getting that in the way. Good. All right, just like that. And then what I am going to have you do when I tell you, I'm going to have you take in a breath, and then you'll blow it out, and then you'll take a second one in and hold it, okay? All right, I'll tell you when to stay just like that. Go ahead, take in a nice deep breath. Blow it all out. One more deep breath in. Hold it. Beat. Good. You can breathe and relax. Now I am going to go ahead and set this up for an upright abdomen. So I backed out and I went into abdomen. I'm at a 40-inch. I am going to go to the wall bucky though, since we're there. And I'm going to set this at 80 kVp. At 12.5, 12 or 15, I'm going to go with 12 because my patient is Sthenic. So 40-inch SID, wall bucky, 80 at 12. You notice that I didn't shield on the PHS, and that is because that typically where we are, shielding is kind of gone away. They found that according to the AAPM report, that shielding actually does more harm than good. So we have not been shielding in Florida, I feel like, for quite some time. So that's why you'll notice in these videos there is no shielding taking place. All right, so we came into 40-inch SID, and we are still going to go 14 by 17 on this. And come down a little bit, I think. And now the patient's going to be facing out, so left side will be this side. So marker goes down in the left lower corner. We'll bring you over here and put your back against the board for me. Stand up nice and straight. Get you in the middle. So I'm making sure she's in the middle. And then I'm gonna find iliac crests, which are right here. And then I'm gonna go 2 inches above iliac crest. So 3 of my fingers is 2 inches. So I'm gonna bring this down to just above my fingers. So iliac crest, 3 fingers, I'm right there. Then I move the tube, so I'm gonna move the bucky down so that that's aligned. And I'm in detent. Just make sure she's in the middle, just like that. And her arms can stay down by her side. Typically what they tell you is when this is positioned properly, usually what will happen is the top of the IR will be about the level of the axilla, and I feel like we're pretty spot on with that. So I feel like this is gonna be good. All right, I'm gonna have you just like that, and when I tell you, what I'm gonna have you do is take in a breath and then blow it all out, and you'll hold it out, okay? Okay, just like that. Take in a deep breath for me. Blow it all out. Hold it out, don't breathe. Beep, good, you can breathe and relax. And now what we are going to do is set this to the table bucky, 40-inch SID, 80 at 10, and we're gonna do a supine abdomen. So, move this out of your way. All right, we'll let you come over here and have a seat on the table for me if you can. You just lay on your back. First thing you want to do when you have a patient on the table for any kind of exam is to make sure that they are straight. Make sure they're still in detent. So as soon as I get this positioned, so I'm at 40 inches, and you see underneath there it says to the grid. So I'm 40 inches to the grid. And this IR, I'm gonna do this first one that was left in the bucky on accident. We're gonna go ahead and put that in lengthwise. So we're aligned there, it's in detent. We're at 40 inches. And I'm gonna make sure my patient looks straight on there, which she does. You do not have to keep your feet like that. And we're gonna come down. So this bottom image, now according to the registry and according to ARRT, a supine abdomen only has to include pubic symphysis. Nothing is needed as the top border of the diaphragm, but most of the radiologists that we deal with now want both borders, which requires on an adult 2 images, meaning the bottom image will capture pubic symphysis and the top should capture diaphragm. So what we're going to do does go against ARRT and against what the registry teaches, because a supine abdomen does not show air fluid levels, but we are gonna do what's expected, even though when we take the registry, we know that that is not the case, that we need diaphragm on this image. So our first image is gonna be the bottom image to capture pubic symphysis. So I'm gonna palpate the patient's greater trochanter, which is right here. And then if my patient's okay with me touching her, I'm gonna palpate pubic symphysis, which is right here. And I need the bottom of the light field to include that area. So I'm gonna come up just a little bit. Make sure I'm in the center, which I'm good with that. I'm gonna have her stay like this, and I'm gonna grab my marker. And we're gonna put left marker down, and that marker likely will show up in her femur, which is not pertinent anatomy. So I'm gonna have you do the same breathing where you're gonna breathe in and then blow it out and hold it out, okay? Okay, go ahead and take in a deep breath. Blow it all out. Hold it out, don't breathe. Beep, good, you can breathe and relax. Now this next one, what we're gonna do is what we would call a T-shot. So I'm gonna move my marker so that I can have overlap to show the radiologist that we did not miss anything. I'm gonna take this out and turn it crosswise. And then this area will give me, it'll be on the first image and it'll be on the second image, because I'm gonna change this to 14 by 17 crosswise. And then I'm gonna move my patient down so that that marker ends up in the bottom of the second image. And what that proves to the radiologist is that this area right here is overlap. That's probably about 2 inches that will be on the first image and will also be on the second image, so that there's no anatomy that was missed or left out when the radiologist reads that. So I'll make sure she's in the middle, which she is. And then I am going to put this marker on the left side of the patient and make sure that it is visible like that. We're aligned here. And then one more time, I'm going to have you breathe the same way for me, okay?
Okay.
All right. Take in a nice deep breath. Blow that breath all out. Hold it out. Don't breathe. Good. Beep. All right. At this point, I would go check all those images and make sure that those came out. As long as they did, I don't want to forget my marker. I'm going to move the tube completely out of the way so that the patient has no chance of striking her head or any other body part on that. I'm going to move this out a little bit. I'm going to let my patient sit up. You can sit there for a second. And then if those images came out, I would take her back to the dressing room, let her get changed, tell her that the radiologist would read those and send them to her doctor within 24 to 48 hours, and then I would walk her back out. And that is an AAS on a sthenic patient.